today. Okay, so first of all, thank you very much to the organisers for giving me the opportunity to talk about our work today on dynamic consent, which we have done through the development of the Control web application. So just to provide a bit of background context to the study for which we have developed and trialled dynamic consent, I want to start by briefly introducing the Australian Genomics Research Program, which in its first 5 years delivered a health services research project with the high-level goal of informing the evidence-based implementation of genomic medicine into the Australian healthcare system. So the research was comprised of 4 main program areas, which you can see along the top of the figure. Underlying and intersecting with all of the programs of work are the rare disease and cancer flagships, as well as the more recently added reproductive carrier screening project, which is also known as Mackenzie's mission. So there have been 6 cancer flagships and 13 rare disease flagships, which have enrolled participants to have diagnostic genomic testing. And those flagships, combined with Mackenzie's mission, will recruit up to 25,000 participants for genomic sequencing throughout the program. So how the flagships work is that we prospectively recruit participants to have genomic testing done, and these participants have never had any genetic testing done for their condition before. We apply genomic testing through diagnostic sequencing providers at the same time as capturing the health costs associated with the intervention, and we also ask participants to undergo participant surveys and evaluations during the study. By doing this, we can identify the impacts of genomic testing. So first and foremost, to determine the diagnostic efficacy of genomic testing, but also where genomic results can be used to alter the management or treatment of a person affected by a condition, but also look into family management and to improve patient choices as well, such as future reproductive choices. So the data that we've collected through the flagships is stored in our centralised cohort in a REDCap study database. We have a centralised cohort of nearly 3,000 participants' data in this database, with another 2,000 participants' data managed externally. The data includes records of consent and agreement or options about future data sharing. We keep their clinical and phenotypic data, along with the genomic results and also the surveys that they complete. We have almost 3,000 surveys completed across 11 of the flagship studies, and these surveys are related to health economics, clinical utility, and patient experience of genomic testing. We also have a separate genomic data repository, which is ingesting data from the diagnostic sequencing laboratories all the time. And I think we have more than 2,000 participants' data now ingested into the GDR. So one thing that we really readily acknowledge is that how complex the consent process is for genomic testing, and especially for genomic research. So when we ask participants to provide consent, we have to make them aware of factors like the implication of their genetic results for other family members, the likelihood that, or the possibility that they might get results that are uncertain, that there might be unexpected or unrelated findings that come up through having the testing, or they may have experienced implications for access to certain insurance products. We also share their data, ethically approved for different purposes. And also, because we've committed to sharing this big legacy data set that we have for future research, we also want to seek upfront consent to that potential future research use. Now, that future research must meet the criteria of our data access request process, and it must also be previously ethically approved through a HREC. So it's really difficult to convey all of these consent concepts through one recruitment and consent process or consultation, and also through that paper-based form, the PICF that a participant takes home. So through our study, we were really looking for ways to improve upon the standard consent processes. And we also wanted to give participants the opportunity to have a great deal more say over how their information is used for these future research projects. So for all these reasons, we wanted to trial a dynamic consent approach. So dynamic consent means slightly different things to different people and organisations, but essentially it refers to personalised online consent and communication platforms that provide a consent mechanism as well as a means of ongoing communication. They're an information and communications technology rather than a paper-based tool, and they're participant-centred, granular, flexible, and can be adapted. And the key characteristics of dynamic consent include that participants need to be able to review and make changes to their choices about research participation in real time. They're delivered in a digital online format, and they promote two-way communication between participants and researchers, as well as opportunities for ongoing patient engagement. So it's been several years now since we began work on designing our own dynamic consent tool, which we've named Control. So this slide outlines the process, and I won't go into the whole process in great detail. But importantly, we started by establishing a multidisciplinary working group to deliver the project. It was represented by around 12 members, and importantly, we had a patient advocate who came to us through the Breast Cancer Network Australia, and also a consumer representative on the group. We engaged the digital health technology developer Curve Tomorrow to develop Control as a web application rather than a mobile app. And Curve, throughout their involvement in the project, used their own user experience research design process that focuses on user experience and design thinking principles. And importantly, they got iterative user feedback on the design at every stage during the development process. So at the same time, we developed the written content of Control, and it was written to harmonise with the current clinical and research genomic testing consent forms that are in use at the moment, with a real focus on simplifying language and compartmentalising core consent concepts. Since the development has been completed, we've had Control approved for use in our study through 4 different HRECs and 32 governance offices of our recruitment sites nationally. And one thing that might be of interest to this audience is that one thing we did was that we found really valuable was that we engaged our lead HREC early in the development process and kept them up to date with our plans and progress. And then when it came time to submit Control as an ethics amendment to our protocol, we requested to present our amendment in person at the HREC meeting. So if you're interested in more details about how we designed and developed Control, we published in the European Journal of Human Genetics at the beginning of this year on this whole process. So I don't have time to do a full walkthrough of the platform in a short talk like this, but I just really wanted to show this screen recording of me working through the platform, just to give you a feel for the look and the feel of the software that we've developed. So that was the dashboard in which a person can access all of the steps. This first step is a short video explaining why we're introducing dynamic consent to our project. This second step is the first step for providing consent to be involved in the program. You can see it's arranged in a series of short statements that participants tick off as they go through and acknowledge that they understand. But there's these accordion sections that they can expand upon with each point so that they can get more information about points that they're not quite sure about. And that allows people to tailor the consent process to their own information needs. It also cuts down the walls of text that you see in regular paper-based consent forms and allows this sort of stepwise consent where a participant can understand a concept, check off that they agree to it and then move on, rather than providing one overall consent at the end of the form. So there are a couple of ways that people can check out Control in more detail themselves. So we have a short video available on our Australian Genomics YouTube channel that does a full walkthrough of all of the features of the platform. We also, for people who'd like to have a play with it themselves, have a demo version available online at the URL on the screen there. And we just get people to use this standardized study ID number that's here. So control is also mobile and tablet responsive. Just showing some screenshots from the mobile phone here, which is really important given the way that we know people use the internet, particularly for non-work purposes these days. They're typically on the go and not using a desktop computer, so the content has to be really digestible in those devices. I include this slide partly as well because I really see the next implementation step for control is to be in-clinic consent on a clinic tablet or mobile device to firstly guide the consent conversation with the health professional and then provide consent. So on the left here is a map of the whole control web app as it has been developed so far. So the consent steps are shown in green while the other parts are shown in blue. I just want to focus the discussion over the next couple of slides on one part of the consent steps that we've built into control, and that's the consent for future research use of samples and data. So it's, as we know, typical for paper-based consent forms to seek broad agreement for future research use of data collected in a genomic research study. But we've incorporated a more granular and dynamic approach to this, and we've applied newly developed international standards to do so. So you can see on the right, there's just 8 questions here of, I think there's a total of 12 questions we ask participants about future use of samples and information, but just showing the first 8 here, which are broadly categorized as who can have access to my samples and information and what kinds of research can they do with my samples and information. So we developed that series of questions on the previous slide to directly align with the data use ontology standard, which has been developed by the Global Alliance for Genomics and Health, which is really the international standard setting organisation in the genomics field. So DUO was developed because every institution uses a unique language in their informed consent forms to describe the secondary use restrictions and conditions on their data sets. So what this means is that there's very little interoperability between systems and between different organisations with respect to reuse of health data. And so every data access request has to be manually evaluated. This in turn slows down processing of requests, and then altogether this means a slowdown of the pace of research. So to add to this challenge, the data use ontology, to address the challenge, data use ontology allows organisations to annotate data sets with codes describing data access and use permissions, which means that DUO provides unambiguous shared understanding of data use conditions. So just to provide an example here of how you combine the DUO permissions and modifiers, how it would work in our study is, so the data is controlled access, there's no open access data, and we might apply the general research use permission term and combine that with some other standard modifiers such as IRB, that ethics approval is required for secondary research, or that it might be restricted to no population origins or ancestry research. So this slide demonstrates how DUO is applied across throughout the data access request process. I think in the interest of time, I'll probably just brush over this one quite quickly, but I guess in our application of DUO to control, we're addressing this first step where consent clauses are encoded using the data use ontology. And it can be applied across the different steps as well. So in step 2, a data depositor or a researcher who has finished a research project and is uploading data sets to a centralized repository can code the data sets with these data use terms or annotate with these terms. And then a person who is interested in using the data held in that data repository can then go and directly query the repository with, knowing the terms that are applicable to the research that they want to do with that data. And this means that they can very quickly and easily get a feel for what data sets might be available to them without having to involve the data access committee at this stage. They can submit a data access request using the Duo codes to code the type of research purpose that they want to do. And data access committees can either manually or semi-automatedly assess such a request and then release data to the researcher. So here, I just want to point out that in our implementation of Duo through control, we're talking about each participant's data set as an N of 1, as they get to choose their own data access permissions. So this is, to our knowledge, one of the first times that this has been done. Just to say that Duo is currently being implemented worldwide, and the uptake of these big organisations internationally will play a big role in mainstreaming of Duo. And there are already in Australia further implementations of Duo in the planning stages, and in work that we've been involved in, there's a project on improving the discovery of clinical trials data sets. So now I just want to focus away from the development and design process onto how we're using control in our study. So our first implementation of control has been the gradual introduction into the Australian Genomics flagship projects that I mentioned in those first few slides. And specifically, we've been implementing it in the cardiac genetic disorders flagship. So how it works currently is that participants still have their study recruitment appointment with their genetic counsellor or other study personnel, and they provide consent in the usual way, signing off on a paper-based consent form. But at the time, the person recruiting into the study talks about control and gives them a flyer with the consent form. If they're interested in signing up, the participant that is, they receive an automated email with the URL for control and their study ID, which is all they need to do a self-directed registration into the study. So I think it's important to say that we're also evaluating control as we implement it, because there has been a lot of discussion about the benefits and potential limitations of dynamic consent over the last decade or so. So some of the proposed benefits that dynamic consent can offer is, better patient engagement or participant engagement with research projects that they're involved in, greater autonomy in decision making. This means that participants don't miss out on research opportunities because they have concerns about certain aspects of the project. Participants are likely to have better understanding of research because by accessing the platform, they can revisit study information at any time. They can see study updates through the platform and that sort of thing. And altogether, this is thought that it will lead to an increased trust in research for research participants. From an organisational point of view, it allows better records of consent to be kept, so no trailing through paper copies of consent in filing cabinets every time there's a question about what consent was agreed to by a particular participant. It allows for clearer data sharing frameworks and data interoperability, as I've described through the use of our application of the data use ontology. It's actually been shown to lead to better completion of research tasks by research participants, for example, in the increase in the number of surveys that participants complete through the platform. And if participants have a greater willingness to participate in research, if they have a good experience through using a dynamic consent platform, this only benefits the research sector. Some of the limitations or remaining criticisms that have been raised in relation to dynamic consent include overburdening of participants with too much contact, or also too much decision making. And there's a debate around whether the decision making should really be transferred to participants, or whether some of these decisions really should be left to the governance bodies and regulatory bodies rather than transferring those burdens to participants themselves. There's also concerns about startup costs and the increased administrative burden of delivering dynamic consent. And there are also, really practical implementation challenges like, changing the culture, changing process and giving training, and, whether there are IT limitations in hospitals that don't support these sort of systems. So, as I mentioned, we're doing an evaluation study alongside implementing control. And in this instance, we're focusing on patient interaction and participant experiences of using control. I can see I've got 2 minutes left. Is that right? Yeah, sure. So just rushing over this, our evaluation is divided into 3 major questions. And I'm just going to show a couple of slides really quickly on the second question about what preferences for future research that participants choose. So this is unpublished data that we're still collecting. So it's really just giving you a feel for it. On this slide, I just want to draw attention to the fact that nearly 35% of people say that they don't want their data shared with commercial entities, and another 22% are unsure about it, while people are more keen to share their data with government organisations and institutions involved in research. On the next slide, people are pretty mixed about what kinds of projects that they would like their data shared to, but very generous in terms of biomedical research. In this set of questions, I just want to draw attention to the fact that nearly 70% of people would like to be notified every time their data is shared to a project, which, tells us that people want to be engaged in research. So while the data set is not complete, people do vary in their opinions about the use of data, and it supports the continued pursuit of dynamic consent platforms. I'm going to skip over these slides, and in the last minute, I'm just going to touch on what's happening with control in the immediate future. So in 2021, Australian Genomics has moved into a new phase where we're not really running our own cohort flagship studies anymore, but where one of our 2 main objectives is to support other research projects, programs in their delivery of genomic research by improving their efficiency, reach and timeliness. We've developed a set of core capabilities to do this. The full list is published on our newly launched website, but you can see that access to control for adaptation and application is one of our key support capabilities. So what this means is that we're making control available to anyone who wants to use it. And we're working to make the control code base freely available via the open source GitHub repository from the beginning of 2022 under a non-restrictive license. And so we hope in this manner that it'll make it really easy for others to access. And we can hopefully as well maintain our ability to track the impact that control's having, be acknowledged as the original source, and hopefully share in some improvements. And just to acknowledge all the people that have been involved in this work. So thank you.
Thanks, Matilda. That's wonderful.